Good evening. I'm David Reisig, and welcome to another edition of SIF Virtual. I'm pleased to be coming to you today with a number of my friends and some real superstar interventional cardiologists from around the country. From Phoenix, I have my good friend Ashish Prashad. From our own program in Scottsdale, we have Bimal Padalia and Malik Shah. And from the East Coast, we are so honored to have Sunil Rao from Duke and from Mass General Farouk Jaffer. Have I missed anyone? I think that's everybody. We have a couple of really great coronary cases to discuss. So this is another edition of Interactive Case Reviews. Ashish, you have a terrific case. Why don't you lead off and go over your case, and then we'll have some discussion over this.
Thanks, Dave. It's my pleasure to be part of SIF Virtual. I wish we could have had the real meeting, but times are what they are. And so we'll make the most of what we can with this unbelievable StarCast audience of panelists we have, plus hoping that we're going to get some really thought-provoking discussion. I picked a case that is, I think, for all the right reasons, controversial in many ways. And so I thought that we'll get some thoughts flowing and then review some data and then also discuss some technique. So that way we get a little bit for everybody that's interested while they're on. So the data lovers will hear some data, and I'm sure the technique lovers will get some good tips and tricks on handling left main bifurcation. So without giving too much away on the case, I'm going to share my screen. So I have a really interesting case, and I'm really curious to get the views of all my friends with us today. So let's kick it off by going over the clinical history a little bit, and then we can look at some angios. So this was a 72-year-old female that was presenting to an outlying hospital about maybe 120 kilometers or miles from where we are in downtown Phoenix. She presented there with an inferior STEMI and was taken to the lab. The thought was that the presentation was late. She was found to have 100% occlusion of the right coronary, which was the culprit, and was also found to have complex multivessel disease of the left side. Because I think the interventionalists there thought that this was an O type of patient, and the infarct had been completed based on enzymes, et cetera, decided that he was not going to intervene on the infarct artery and left it alone. He put a balloon pump based on what he thought was ominous disease of the left system, and she did pretty well. I mean, she basically had no heart failure, no post-infarct angina, no major dysrhythmias, and a balloon pump was taken out at 48 hours, and she was discharged in 72 hours on good guideline-directed medical therapy on DAPT. Ejection fraction was normal on discharge. And the game plan was that given that she had what he thought was surgical disease on the left side, she was going to see a surgeon as an outpatient for revascularization timing, depending on how she did over the next several days or weeks. As it turns out, she literally stayed home for 2 days and then was readmitted with a GI bleed. And this time was found to have ulcerated mass in the cecum. She needed 3 units of blood. DAPT was held transiently. She was endoscopically treated with a clip. Luckily, the mass biopsy turned out to be benign. And then the general surgeon or the colon surgeon was planning to do a hemicolectomy to minimize her risk of obstruction down the road. So that's the scenario. It's complicated in and of itself. So any questions, any kind of any further information that Sunil or Farouk or any of the other guys want?
That's that you're setting up a really complex case. So that's great. Sunil or Farouk, any further info you need?
Well, it's interesting. So a couple of things, when you saw this case, probably you were sort of scratching your head about. I mean, no intervention performed, normal ejection fraction, yet she got a balloon pump. It's an interesting kind of clinical scenario. I mean, obviously, none of us were there. It's hard to understand the rationale for some of the clinical decision making. But now you've got a lady who basically has had a massive stress test, soon after a STEMI. I mean, she had huge GI bleed. I assume that she got fairly anemic, and that's a pretty good stress test. Do you know, did she get any chest pain with the GI bleeding? Did she have markers cycled again? Did she reinfarct in any way at all?
I don't have that information, but I did know that I talked to her after, and she did say that when she was admitted the second time, she had some recurrence of angina. It was thought to be mild, but she wasn't she was immediately got scoped, got 3 units of blood, and once she was tanked up, she was fine again. So it wasn't, she had some transient EKG changes, some chest pain, but nothing with like a huge repeat bump in troponin or anything like that. And this is a hospital, by the way, that does not have on-site CT surgery, if that sort of makes some sense in the sense of kind of behavior of the interventionalists there, although unusual for us at our centers to do the kind of stuff he did. This is sort of not unusual for a community hospital out in the boonies without standby cabbage surgery.
Mechanistically, looking at the normal ejection fraction, it's really, potentially one of two scenarios happened. Either there was recanalization or there was substantial collateralization that formed quite aggressively. That maybe the initial angiogram may have provided some clues to that. But I think one of the nice things about this case is that, after having a quote STEMI, often there'll be a consideration of viability testing with a normal ejection fraction. We know this is a viable zone.
Yeah.
And that helps your decision making. I'm sure we all have many ideas going on through our head about how do we handle the acute right coronary occlusion in the setting of residual severe left coronary disease. And that alone is an interesting discussion about angioplasty, definitive stenting, followed by bridging, or emergent cabbage, which is probably the least likely and not really applicable here. I'd love to hear what people think about that.
So was the decision to proceed with mechanical support based on the anatomy at the time of cardiac catheterization, or was there a time prior to transfer or prior to discharge when the patient was hemodynamically unstable, or we don't really know that information?
No, the balloon pump was put in at the time of the index presentation for the STEMI. So the balloon pump, I think, was put in because I think, and this is just me getting into the guy's head now, is that I think he wasn't sure how she was going to behave over the next 24 hours. He was obviously perturbed about what he saw in the left system, and needed some sort of at least protection in his head before, if she crumped, then transferring her urgently to a place where she then could get either emergent PCI to the left system plus minus PCI to the right if necessary, or whatever else, or if she went into shock. I think is where I think he was thinking that he just has got to do something because he wasn't revascularizing the right. So he just, I think, put a balloon pump, whether that's mostly to treat himself or there's no data to support what he did, obviously, but that's just the way things turned out. The time that she was sent to us was after the GI bleed, because obviously nobody wanted to touch her. And he thought that the question was she may need a hemicolectomy sooner rather than later. And they wanted her then transferred to a center of higher level of care.
So Sunil,
without a balloon pump, on telemetry, hemodynamically stable, on no pressors. And I'll show you her labs, not unusually, not really bad.
Yeah, show us the labs. And then Sunil, I have a question for you after he shows the labs.
So this was her other relevant information. Her creatinine was 1.5. Her hemoglobin was 9.8 after the 3 units of blood. As you can see, she's got some Q waves in lead 3, but really no other completed infarct pattern. And as Farouk rightly and astutely pointed out, the collateral theory obviously was one of the theories that I was thinking about, and it sort of is kind of evident when you take the left-sided pictures. You can see that there's sufficient filling of the PD and PL, which is probably why she didn't significantly have a negative impact on her overall ejection fraction. But interestingly, look at her BMI, she's 49.7.
Right.
So she is a big, big patient. So that's kind of how she showed up to us. And
so what was your next step? What was your next step in this?
Yeah, so I mean, I think the mic. Let's see what Bimal and see what Malik and Bimal would do. What would be the next step? This patient shows up at Honor Health, and Bimal, what would be your next game plan here?
I mean, we really need to look at the angiogram, right, in terms of how complex that left system is.
Mm-hmm.
The issue is she's going to be, these are one of those cases where it's tough for the interventionalist, it's tough for the surgeon as well. This patient's going to be high risk. And so the idea is this patient may not be able to tolerate dual antiplatelet therapy for a substantial period of time. If you can get a good PCI result, large lumen, very well expanded, newer data seems to say that in higher risk bleeding patients, we still may be able to get away with 30 days DAPT, or definitely 90 days DAPT, maybe 30 days DAPT. So the angiogram would kind of, tell me which way to go in terms of revascularization, and definitely an imaging guided modality to make sure you get as perfect of a result as possible.
So Malik, if this patient came to you, what's your initial approach?
Obviously, hopefully would want to take a very comprehensive approach to the care of this patient, involving the patient, the general surgeon, as well as the cardiology heart team. I think in this particular situation, this patient has had a significant GI bleed, so would have to weigh any therapy that would require dual antiplatelet therapy, whether it be for 30 days, 90 days, or 180 days critically, against the potential risk for ongoing life-threatening bleeding. And obviously consider other comorbidities, including the patient's morbid obesity as evident here. So definitely would have to review the films, have open dialogue with the patient and the surgeon to figure out what's the best pathway forward for the care of this patient.
So the images were power shared, and I ultimately was able to get a hold of the interventionalist over the phone, who was apparently he was on locum at that hospital, so I had to literally track him down during his time away, because this was during the weekend that he had done the case. And bottom line, I find out that the thought process was what I said. He thought it was a late presenting inferior wall MI. The right coronary seemed closed, and the left system he described as having a lesion in the OM system and a lesion in the ostium of the LAD, and he felt like that was surgical. So the case was then left to the guy picking up the case, and then this GI bleed happened. Our surgeons, which is typically what happens when patients get shipped down, heart team decision up front was that A, given the morbid obesity, B, CKD, and just the overall poor surgical rehab potential, the situation probably was turfed back to the interventionalist, i.e. myself, to take care of. Our surgeon said, thanks, but no thanks. So we can then look at the angios, and then we can talk again.
The only other thing I would say while you're teeing up the angios is this patient, irrespective of what therapy, has chronic kidney disease, substantially reduced GFR, and a preserved DF. I'm beginning to hydrate this patient almost the minute I get this patient, because irrespective of what therapy, surgical or transcatheter, this patient receives, kidney issues are going to be pertinent to the prognosis. So I start hydrating these patients up gingerly, mind you, almost immediately.
So Sunil, can you see? So I was a little bit wary of repeating the angio, which is often the case because of her creatinine. But in any case, we had the power share images by the time I ultimately we got the heart team, and so I had 24 hours to get all that together. We were able to look at the images. So I went in with a game plan here, obviously with a guide in the left system, which sort of gives it away. But what do you think is going on the left with the angio?
Well, I'm not seeing any blowback into the aorta. That's the first thing.
Yeah.
Yeah. I mean, it looks like the left main's hugging the catheter there.
Yeah. Yeah, and I think that's happened. It happened immediately. I could tell because we had a 6 French slender in the wrist, and obviously a 7 French guide was impossible. Even a 6 French guide with side holes was which is what this is, and you can really tell that there was significant dampening and there was hardly any flushing back into the aorta. So Farooq, what do you think is going on other than obviously what was described to me in the left system as a lesion in the OM and circ system, and then Proxel AD? Obviously, that completely missed this left main business altogether and didn't even tell me anything about this. So that came as like a surprise.
Yeah, that's the worst chocolate to get.
Yeah.
So this is it's a really super important angiogram that you now have in front of you. This is just an incredibly great case for discussion because I think the main question is timing for revascularization. I think we would probably all agree here that we have a left main with a concomitant 3-vessel disease. We can use physiology for the OM to confirm, but anatomically, I think we would meet that criteria, and so it's likely to be at least an intermediate syntax score. And I'm not sure if you guys are formally calculating that, but at least into gut feelings of tertiles, it's at least intermediate. And so now the question is what do we have to do it here? Because if we're looking at left main intervention, do we have to do this admission right now? We are really going to favor potent DAPT. That is really the one thing that we're going to want to use. And in the setting of a recent GI bleed, I think this is the most critical concept to understand is if she's tolerated a STEMI and now 3-unit GI bleed with that left main, maybe we have time to ensure that she is optimally stabilized from a bleeding standpoint. And I might consider even interventional radiology consultation. I didn't quite get the pathology that was discussed in the CECM, but just understanding that before we went in to proceed with left main PCI might be the one medical triage point for me.
Farooq, is there any role anymore? Is there any role for baremetal stents? I mean, that's the people. Oftentimes we had a case very similar to this not long ago, a patient who had left main and needed a Whipple. Is there any role for baremetals anymore?
I really think it's really close to zero now after Onyx 1 was just published in the New England Journal. And she would really qualify. She's a high-risk bleeder, no question, both even before her GI bleed with her GFR and age together, she would qualify for the Onyx 1. So the answer to me is no. I think the only time I would consider this in extreme situations, if there is a known definite surgery that must happen, and there is a concern about still being off-label from an FDA standpoint, where once you place a DES, and there's considerations of bridging concerns as well, then I think you could have an individualized discussion, but I would say it's a less than 1% chance that would happen.
So a quick question about so as to answer your question about the GI issue. So we obviously got our GI guys involved up front, and their take was that the scope and the appropriate clip that she had at the outlying facility and the fact that the pathology was benign made them feel like the likelihood of rebleed was in their opinion low to intermediate, and they felt like 1 month of DAP was something that they would not be opposed in terms of waiting to go after the lesion with a hemicolectomy, which would be the definitive treatment of choice. So that was the discussion we had up front. That's an important discussion to have up front, I think, before you bring this patient to the lab, because this is not a time to, and becomes relevant because the minute we put the guide up and the minute you can see I have 2 wires in pretty quickly because she started really going south. I mean, just the temporary occlusion with the guide and the drop in pressure. She started having nausea, and she started having chest pain, and her pressure dropped to 60, and she was getting diaphoretic. And I was sort of getting a little bit antsy because I was now getting to a point where, this is a situation where, from being a quasi-stable thing, this was potentially getting to be dangerous in the lab. So this is no time to pick up the phone and call a GI guy at this time. I think it's all that needs to have been figured out up front, and that decision was already made.
It is an incredible predicament. I think it's as soon as she develops instability, I think you're forced to act. At the point prior to that, I think the reason she's developing instability in part is probably also having a hypokinetic inferior wall.
Yeah.
We've definitely seen that, right? And so she's soon after this MI. She sounds like, there's really CABG is going to be a non-consideration here with, the active chance of bleeding and her overall potential chance for sternal malunion. Did the surgeons, was there discussion about hybrid approaches? Is she a minimally invasive lima candidate?
You guys
our guys,
no, our surgeons are not. So unfortunately, we have a fabulous group of surgeons that, do a bunch of valve work with them. But from a coronary perspective, they have not embraced the whole hybrid concept. And you can debate that based on the data. But I think that their take has been that in the rare instance, where there's a lima with a CTO of the right, there's a LAD lesion and a CTO of the right, then I think in those circumstances, they treat the LAD, and then in a separate admission down the road, if the patient is still symptomatic and has ischemia, then I'd bring back to fix the right. But in a setting like this with a complex ostial left main, circ lesion, LM lesion, and ostial LAD lesion and a mid LAD lesion, I have very rarely had any kind of luck with our surgeons discussing hybrid revasc. It's either one way or the other. I'm curious to see what Dave thinks about that and what Sunil and the approach at Duke is.
I'll defer to Sunil at first.
Yeah, no, I agree with you. We're not doing much hybrid work at all. And I think I agree with Farokh here. You're going to go into this case with the intent to, open these lesions because she's clearly proven to be not a surgical candidate. And I think just the fact of seeing her clinically deteriorate just with the guide and injections is incredibly worrisome. So, yeah, I think your plan is the right one, and we would probably approach this exactly the same way at our center.
Malik, I think a lot of people still do these cases without imaging. While there was a high penetration of imaging in the XL trial, it wasn't mandated. Why ultrasound or OCT? Why imaging on this?
I think the most important thing that we can learn, obviously, on this also is just the first time the angiogram was done, there might have been a moderate stenosis in the left main that wasn't well interrogated. And I think left main disease is one of those things that has a significant amount of inter-observer variability in the way we assess the severity of these lesions. But a left main stenosis can impact a high amount of ischemic burden in the heart overall. So it's almost most paramount in those situations that we actually do further characterize, interrogate, or delineate how significant the disease is. And had that been done the first time in the first angiogram, I don't know the exact clinical scenario in which the patient presented the first time, such that if there was time for IVUS, but if they had interrogated with IVUS or OCT, or in some way even assessed it functionally, I think it would have given Ashish more data up front to figure out how important the left main was going to be. And so I think it is critical that we characterize these lesions with intravascular ultrasound imaging, if at all possible, or something else like OCT.
I'll also say that there is, I totally agree, but I think there's also a difference between, doing imaging and then understanding what you're looking at and then acting appropriately. Because a lot of folks who, I shouldn't say a lot, but there's not a lot of education on intravascular imaging during fellowship programs. There's a minimum level of number of echoes you have to do. but there's no minimum number of IVUS or OCT that you have to do. And so folks will run the catheter down, up and back and take a look. And we get a lot of folks who have left main stents that are severely undersized. And you go back and you look at the report and they used IVUS. They just were unable to interpret the images and understand exactly what they're looking at and how it should affect their strategy. So there's a big educational gap there, I think, for interventional cardiologists who are both in practice or who are in training right now.
I couldn't agree with you more.
Yeah. So Ashish, next steps.
Yeah. So, I mean, I think Farouk was very astutely talking about his gestalt about what the syntax score is. And I kind of, for purposes, we don't typically do this on paper for every case, but obviously for purposes of the one thing that I did want to bring up is, again, incredible calculator variability on how you estimate the score. I mean, it all depends on, like, so if somebody that didn't think that the ostial left main was real, like the guy who did the procedure, would have just called this an ostial LAD, proximal circ, and then the RCA acute occlusion. So, I mean, I think now it changes the whole thing, because now you're looking at a bifurcating distal left main lesion with an occluded right and an ostial left main and a lesion in an OM. And so I think what you plug in, it's like garbage in, garbage out, like everything else. So, I mean, I think goes back to just like what you were saying for the IVUS interpretation, Sunil. I think that you need to be able to accurately do this. So I encourage, especially fellows in training, to try to take a dab at this on their own in cases that they look at with multivessel disease, and then sort of tally it up with how an attending or somebody else with more experience would calculate scores. And in this case, as you said, the score, with your experience, you were able to immediately tell that it's probably going to be an intermediate syntax score, which it was, 19. And then, of course, plugging it in with the other clinical variables like her age and renal dysfunction and her LVF, we came up with the syntax 2 score, which suggested that she would have a syntax score mortality with PCI of about 56 and a 46%, and with CABG would be about 24.8. And the recommendation based on the app was CABG or PCI, which is irrelevant because she was a surgical turn down anyway. But just so you know, we did this specifically for this case review, but I encourage operators around the world and around the country that are reviewing and looking at this webinar to actually try to do this and practice in their labs on a clinical regular basis.
So let me ask one question to the group here, because I actually do calculate the syntax score largely to teach the fellows, and it's always educational to me, because if you look at the right-hand panel of this slide and you look at the PCI 4-year mortality and the CABG 4-year mortality, I mean, these are sky-high numbers.
Yep.
And so the question, I guess, that I'll pose is, do we really believe that this woman's mortality with PCI at 4 years is almost 50%? Or do you think this is driven by the fact that it was taxus stents that were used, it wasn't routine imaging? I mean, and even if you ask a surgeon what this lady's 4 years, survival with bypass surgery is, they're not going to say her survival rate is going to be 75%. They're going to say it's going to be north of 80%, maybe 90%.
Yeah.
And it just makes you wonder about, risk scores are one thing. I think technology and how you use it and technique is also another thing. And I'm curious, when you have a conversation with the patient, my guess is you're probably not telling her that her 4-year mortality with PCI is going to be 47%.
No, I don't think I use this as much as to look at the prognosis, because I think, as you rightly said, it's been, I think, syntax score was, I think, probably, as you said, with taxus stents and without mandatory use of imaging and without contemporary techniques, it's probably not representative of outcomes, but it does, give you a sobering perspective on things that you don't normally think as being bad outcome players. I'll give you an example, like ischemia CKD, okay? Like going back to ischemia CKD, just there's no way that a hemoglobin level of less than 10, a GFR of less than 50 in a patient who is 75 would have, the numbers you see there are astonishingly high. And when it comes to end-stage renal, GFR grade 4-5, it's incredible. I mean, those 5-year mortality numbers are staggering, 50%. So I think that there are things we take for granted in the lab that we don't think a lot about, but they add up in terms of their TLR, TVR, and future impact on mortality that are subtle, that we don't necessarily fully appreciate at the time of doing the index PCI. Would you agree with that?
Yeah, absolutely. I think that's a great way to state it. Yeah.
I think some really important points. I totally agree. Looking at the absolute value of the mortality is helpful, particularly in very high risk frailer patients, to help them understand, between surgery and PCI, they are both, limited by durability. And so that the focus of revascularization often shifts into symptom relief and control, that we're not necessarily focusing on longevity here, that we really want to get you stabilized. And we know that's the case. So in patients who are, less symptomatic, for example, in stable outpatients, that might, help one understand the need for undertaking a procedure can modify it. One thing about the syntax score, and this is such a controversial issue because I suspect it is really infrequently calculated to the degree of reliability or at all. And, it's a challenging score. I think, all lesions more than 50% are counted. In this particular one, I think it would be great to have this as an exercise, all 5 of us do it blindedly, 6 of us, and come up with a number and see what the range is.
Yeah.
I think once you get to 3 or 4 lesions, you're likely to be in the intermediate category typically, especially if they're proximal. And you can see the osteal left main here is contributing to as much as 15 points. Although it's a non-bifurcation one, I think that would probably be, it's coded as a Medina 111.
Actually, there is, because there's an osteal LAD lesion that you don't fully appreciate, and I'll show that to you in the next images, that it's really a bifurcating distal left main.
Oh, is that right? So in addition to osteal left main,
yes.
So this actually will be in the high syntax category, because if your osteal and distal left mains are separated by more than 5 millimeters, they're going to be 2 separate lesions. And a 011 is effectively a second left main, is what you may be seeing, or another 111.
Yeah.
So if you have an osteal and a distal left main, you're going to be in the high syntax score, most likely. And I think that's fine. I think if you had a stable situation where you could counsel the patient, choose a surgical candidate, then you might say left main with high syntax surgical score. If you're an average surgical risk patient, maybe you're better off with surgery.
So I think I made a mistake. I didn't quite appreciate what you just said, and I didn't know this, so thank you for letting me know, is that a separation of 5 millimeters, I treated the osteal left main and the distal left main as a compound lesion that included the one. So that's why I put it all as a 111 bifurcation. So I think if I added that into that, then there from 19, you jump to something more than.
It is actually, and even I have to go back and look, because there's one part of the syntax where they talk about being separated by 3 vessel diameters, in which case you might be sufficient to call this one lesion.
Yeah. It goes back to the same thing of how subjective and how difficult it is to truly come to a number that we can all reconcile. No matter what, I mean, I think this is a complex lesion. We all agree, and we all think that this is, surgery is off. So this is really, so of course, going back to imaging, the patient got imaged. And so let's first, before that, any thoughts on how you would deal with the bifurcation if you went back and looked at the angiograms? I know the images are limited by just having two views, and maybe not the best views to open up the left main bifurcation. But if you take my word for it that the left main bifurcation is diseased, there's not much calcium in the left main or in the Prox LAD. There's no intent to use atherectomy. How would you approach this bifurcation?
So Sunil, you and I were part of a roundtable discussion in July of 2012 or 2013. And at that time, the consensus opinion was keep the strategy simple as you can, because MACE is higher with more complex strategies, not driven by mortality, but driven by repeat revascularization.
Yep.
There has been such a rapid evolution in the thinking owing to newer data, newer studies, DK5, et cetera. So right now, given this anatomy, are you shooting simple or complex? Single stent or multi-stent strategy?
It's a great question. And I think that the DK crush data are compelling, but I will tell you that, I think I have some questions about the DK crush data, largely around, it's hard for me to wrap my head around how you have more stent and less stent thrombosis. I have trouble reconciling those two things with DK crush. Plus, DK crush is a very involved process. It seems like they add steps all the time. I sort of get mixed up sometimes when I'm doing DK crush, and I got to have write it out and tape it to the monitor so I remember all the steps. I'm a simple guy. I like simple strategies. I still believe that less stent is better, so I tend to use a simpler technique here. And I'm still waiting for my invitation back to Laguna Beach, by the way, for the second roundtable, David. I'm just waiting for that one.
We're doing it this summer then.
All right. Farouk, what would you do?
Yeah, to me, the key question is I have to look at the circumflex ostium.
Yeah.
If you study the DK Crush 5 trial in detail, I mean, that is a significant reduction, surprising to be with upfront 2 stents as a DK approach as opposed to a provisional approach. So one has to look, they had pre-specified the complex versus simple lesion subset, and that benefit was shown to be stronger in the complex lesion. And it's important to understand how they, of course, define that. And part of it has to do with the severity of the osteostenosis at the circumflex, the degree of calcification, the angle. So there are many features that can do that. For me, I typically look at the amount of plaque burden in the stenosis. And what I'm trying to understand, and even if you use their simple complex designation, there's still, if you go simple, a 25% crossover back to a second stent. And when that happens, you really, because we know from the BBK data that culotte beats TAP in most non-left mains, and 16% of that trial was left main. And we know from DK3 that DK beats culotte. You would if you're going to use 2 stents, you want to be in a DK position. This is a very difficult case. Personally, I would be, end-seam balloon, reestablishing flow, and then having my academic mindset going about what I want to do.
Does the lesion downstream in the OM, which I know has not been functionally interrogated, but largely because of clinical situation that led me to quickly wire this, but assuming that for the sake of academic discussion, that lesion in that long OM is real, then does that change your strategy in terms of 2 versus 1? In other words, reaccessing through an unstented circ ostium, a lesion downstream in the side branch.
Right, I've certainly done that in cases where I need to stabilize the patient, get the artery open. DK gives me all my access. Yeah. So, a short stent there. This is a pretty wide bifurcation angle, and so you may be able to even to consider provisional with a T-tap at the end in this very unusual kind of wider, greater than 90-degree type.
It looks 90 degrees plus. Yeah.
Yeah. Yeah. So this might be one of the cases where DK, may not necessarily have to get done in the same way, but for most regular angles that are narrower, if there is significant osteoplaque burden and I have stability in the patient, I will just proceed with a 2-stent DK strategy.
Bimal, tell us what you're seeing on these ultrasound images.
Well, Ashish already mentioned there wasn't a great amount of calcium in these images. These are still images, I assume 2 parts of the left main. And what you see is fibrofatty plaque burden. And the image there on the left, not sure what the MLA is there.
5.3, that's what it says up there, right?
Oh, 5.3, got it. Yeah. So the MLA is definitely small with significant lipofibrotic plaque there.
So is the absolute number that we're all using 6.0? Is that the cutoff? Because just to go back, Sunil, when we had that roundtable summit, the number was 7.5, and then Litro came out, and that shifted it to 6.0. Is 6.0 the absolute number we're using?
Yeah, I mean, I think, you know, anything less than 5.9 basically is what I use.
A quick question. Just a reference vessel diameter, just talking about educating people on how to use this. Would everybody on the panel be in agreement that the diameter of the vessel is 5.0?
Outer to outer, yeah, you're looking a
Yeah, it
little.
looks like
Yeah.
it. Yeah.
Yeah, it's fine.
Media to media is around 5.0. Yeah.
Yeah.
Okay, so when they pulse dilate or do a pot, would they be using a 5.0 NC balloon? Is that an expectation?
You do want to right size it to the proximal reference. Whether or not it's 5.0, because if you're at 5.0 here, you're going to potentially have some tissue prolapse and edge dissection. It depends if the plaque runs all the way to the true ostium. I think that if you get to a minimal stent area where you're 80-90% plus of the optimal proximal reference, you're going to be doing great. But 4.5 to 5.0 would be in the ballpark of what I'd be thinking. Really important to give yourself 8 millimeters left of the bifurcation of stent, so you can do a pot without injuring the actual native vessel that's unstented. That sometimes is missed in these.
Forgotten, absolutely, very important. Yeah, exactly. Okay, so we'll keep in the interest of time. So again, I went with a dedicated 2-stent strategy up front. Again, everybody talked about DK, but I think the way I look at treating a bifurcation is side branch first or main branch first. Typically DK, crush, all the typical strategies involve treating the side branch first, but the patient sort of got unstable, and I was more focused on treating the ostium of the left main and the prox LAD and getting that secured first before fighting anything else and making this too academically. And oh, by the way, we didn't even talk about, I'm still in the wrist, whether or not you would get access in the other groin, whether you would plan for support, no support, balloon pump, plus, minus, etc. We'd never even, so assuming that the patient I thought was comfortable before she walked in, her hemodynamics looked, I didn't do a right heart, but the patient had 2 full days of good medical treatment and seemed comfortable on 2 liters of nasal prongs, oxygen, and EDP was normal before we started the case, which I did check. I opted.
I really respect your decision not to go with upfront MCS here. You and I have had this discussion before. I think there's been several interesting evolutions in whether or not you use MCS. Whether you get access in the groin, I think that's a judgment call, and so you're not trying to get access during when you have a really sick or crashing patient. The only other thing I tend to do in these cases now is I tend to upsize to a 7.5 French sheathless guide. We have those. We virtually, Bimmel and I virtually, and Mullick do all of these transradial. We use the sheathless guides, the larger size sheathless guides. And I don't think it's a wrong decision. What you're doing is to go after the LAD first. I think it's how meticulous you are with your sonography and with your final kisses that are really going to make the difference for this patient. So I respect completely the way you went about this, and I think this is very thoughtful.
I don't go crazy with groin access, but the one thing that was always plaguing me in the back of my mind was her BMI of 49.5 and trying to get access with a blood pressure that's borderline was going to be hell. So I said, listen, just do it right, safe femoral, backup plan, ultrasound, femoral access, micropuncture, get it all in. Whether we use it or not, it's there for safety. And like Murphy's Law, when you put it in, you don't need it, and when you need it the most is when you don't have it. So,
and what's your guide size? And what's your guide size right now?
So the guide. So this was the other thing, right? It's a 6 French guide, because anything short of that was just making her very, very sick. If I went into the 7, 6, this is a 6 guide with side holes.
So did you make your own side holes?
I made my own side holes because we didn't have a 3.0 with side holes in the lab that day. So I had to make my own side holes. And then this is a 6 3.0 EBU with my own side holes. So anyway, we put a 4.0 stent based on discussion earlier. starting from the mid LAD all the way past covering the ostium. I don't want to get into the details of whether or not the panel would use osteal flash or not use flash, but bottom line is we treated the LAD and the left main and then potted with a 4-5 NC8 balloon, which you can see in the right panel. And
so in some ways, you're really provisional.
I am provisional but with a wire, with a safety wire in the circ. But yes, provisional, which is kind of a little bit crazy. But I did that because of the fact that the patient got sick on me.
I suspect in this patient who came in stably that this was catheter-induced stunning. Yes. And as soon as you disengaged, you were going to be able to recover her. And I imagine you might have even done the IVUS with a disengaged guide.
Yes.
But nonetheless, you have to treat. And so, you've got to get engagement for some point. And I think this makes perfect sense to stabilize her, save her life for sure.
Yeah, I think you did what you needed to do. I think the save the side branch strategy first, I think those are also good because once you stent that side branch and do your initial kiss, it's pretty hard to lose the side branch. We're always concerned about losing side branches, but that 90-degree angle that you have really argues against losing the side branch. The more narrow that angle is, the more likely you're to lose the side branch. But Farouk brought this up. You have a really, really wide angle here. So I think you're going to be in good shape.
So we switched out the workhorse wire from the circ after we had jailed it and switched it out for a polymer jacketed wire. So I switched it out for a Xion black, which is kind of like the wire I've been going to more often, trying to access side branches. Seems to work pretty well. And once we did that, we pre-dilled the circ ostium with a 2.5 balloon to make room. And then in the left panel, you can see that I pretty much was able to deliver a 40-millimeter stent to cover the entire lesion from the OM all the way back to the ostium of the circ fairly easily. The lack of calcium and the angle obviously worked in my favor. Any thoughts about that? Farouk, Sunil?
Sorry,
wire choice.
I'm seeing just the LED balloon right now.
Oh, on the left panel. On the left panel, you see a stent going in.
Great. Yeah.
You see a stent going in on the left panel?
Yep.
Yeah. So that's a 40-millimeter stent.
Great. And so this was after you placed your 4.0 in the LAD left main.
Yeah, 4.0 LAD left main, potted distal left main, recrossed the circ ostium and OM with a Xion black, pre-dilled the ostium of the circ and the lesion in the OM with a 2.5 balloon, and then now going in with a second stent into the circ.
And so
with a safety balloon in the LAD to crush the stent after it's deployed.
And so do you think are you planning a T-type tap approach here? Is that basically your goal?
This is now committed to a T, which is what I was forced to because I'm now having already treated the main vessel and the LED first.
Yeah, so you're probably obligated to kiss balloons here at the end.
Yeah, exactly.
I think you have to. I think when you look at bifurcations in both the main and non-left main, the number of clinical endpoints and angiographic endpoints that are altered by a final kiss versus no kiss, it's too compelling, and I think you're obligated to a final kiss.
Yeah. So this was the image on the right, as you were pointing out, is the crush of the stent in the circ with a wire and a balloon that was already in the LAD. So basically, prepared to crush up front with a little bit of protrusion of the circ stent into the left main. And then this was our final kiss with 2 NC balloons with a 4.0 into the left main LAD and a 3.5 from the left main into the circ.
What kind of stents are these?
So they're onyx stents in going in from the left main into the LAD. And then I mixed and matched that with ultra thin strut or Cyro 40-millimeter stent to access the circ side branch. So
And your final kiss, do you do a two-step sequential on your final kiss, or just blow them both up at the same time?
No, two-step sequential at the final kiss, and super high pressures in the side branch of the ostium. Any questions or thoughts about Sunil, Farouk?
I have often just used the stent balloon and the NC and the LAD. I would use the stent balloon, pull it back, and do a simultaneous kiss, not a dedicated crush sometimes. I would, for the standard tap.
Yeah.
So I wouldn't pre-crush that stent edge like I would for a DK. I would usually just do that final kiss, but I think you've recrossed and done a final kiss, so at the end it's probably going to be looking the same. I think one of the other final points is about whether or not one finishes with a pot, because that is increasingly being kind of utilized in consensus statements that a final pot can really right size the bifurcation and scaffolding. Are people doing that? I'm curious.
So I used a 5.0. In this case, I did. Because of the mismatch in the prox and mid left main with the ostial LAD and the circ, I ended up taking a short 5.0 by 8 millimeter balloon NC to basically just expand the left main segment of the onyx stent to 5.0 capacity as best as I could. So that was not really a pot designed to optimize side branch diameter as much as to optimize the left main, if you will.
Okay, let me ask a couple of questions. Sunil, minimum duration of dual therapy.
Yeah, I think, if you had, all things being equal, you'd like to have this lady on at least a year, given her recent MI and high risk PCI. The challenge here, I think, is that unfortunately she needs what sounds like major surgery. And I think given, how big a surgery she's going to have, that is going to put her at a little bit of a risk for some perioperative events. So, I think it's a conversation. I think, as Malik said, you want to talk to the GI surgeon, and if they're willing to go 3 months and they think that that's something that she can tolerate, great. If they say, look, this has really got to come out, minimum, I would say a month, but I'd be a little nervous about anything less than that.
Malik, minimum duration dual therapy.
Yeah, I agree with Sunil. I think that the main thing is a discussion with the GI doctors as to the clinical course for this patient. At least, preferably 180 to 365 days. I may not get it, so at least 1 to 3 months.
Farouk, this patient now, a similar patient comes, same clinical story. This patient has no circ disease, has left main disease and prox AD disease, and a pristine looking 3.0 or 3.5 circ ostium. So you do a single stent crossover. Now, how do you feel about dual antiplatelet therapy? Is it any different than a proximal LAD at that point?
I think that unfortunately it is, because of the risk of stent thrombosis in the left main still being a much larger territory. It's just not survivable for most patients. So
what's your minimum duration if you didn't have to instrument the circ?
Yes, I don't think I have data that could suggest that it would be shorter than any other stent situation, although we clearly know that two stent techniques out of the left main tend to have higher stent thrombosis. And the stent thrombosis was actually lower in DK5 compared to the proximal, the provisional approach that Sunil mentioned. I would say I would really push my surgeons to see if I could get away with 3 months. I would transfuse a unit every now and then. If it's a slow bleed, I really, really hesitate about that. And I would still also, I know it's probably aggressive, but I would actually seriously consider bringing this person in for kangaroo bridging before taking them to the OR. We're in the major off-label zone here because Onyx 1 and the BioFreedom trials don't really have a lot of these types of patients in their groups. And so she has the highest risk with stent thrombosis. So I'm a little more on the conservative side.
Sunil, what have we learned from STOP-DAPT that we can apply here in terms of image-guided coronary intervention and the duration of DAPT, what we can, quote unquote, get away with?
Yeah, so it's a great question. And, again, I think to Farouk's point, this woman unfortunately falls outside of many of our clinical trials. So we are kind of extrapolating a bit. I think the thing that we have to keep in mind, though, is that, there are several time horizons here. There's the time horizon of getting her out of the cath lab alive with an open artery. There's the time horizon of getting her to her surgery. And then there's a long-term horizon. And we have to remember that the DAPT is not just for the stent. We want to reduce spontaneous MI in this woman who clearly has coronary disease. So I think what the imaging guidance helps you is through giving you confidence that you are not dealing with malapposition, you're not dealing with undersizing, you're not dealing with underexpansion. But ultimately, the balance here is between the stent thrombosis and the bleeding risk with surgery. And I think the bridging issue is really interesting. I think, again, this patient doesn't fall into any neat clinical trial. She is at the highest risk. I personally have never been a fan of bridging because most of the stent thromboses that occur after surgery, not before. But even I would consider bridging this person because, it's such a high risk situation here and such a big surgery that's going to happen.
So give us the epilogue. Sheesh.
Let's see the final shots.
Yeah, no, so this was, I don't know, I use this a lot. We have these little laminated cards in all of our labs. I think it's useful for the audience that's not familiar with this cross-sectional area idea of how your stent should look after you're done in terms of what the RVDs are. And this helps me a lot because just being sure that at no point within the stent you're below these thresholds at least is at least the least amount of size you should be striving for at the end of your procedure and whatever it takes to get there. So
what happened with the patient?
So she did fine. These are final angios. So the final angio shows she did great.
Beautiful.
She left the lab without any issues at all. The creatinine did bump to 1.8. This is Onyx 1 data. She was discharged on day 3 after the hospitalization. And my plan was to keep her on DAP for a month and then interrupt the DAP for the hemicolectomy. And then obviously my thought was I wasn't going to bridge her, but listening to Sunil and Farooq, I might change my mind now.
No, look, again, not a lot of data to support it, right? So
yeah, now I'm scared because I was thinking exactly the way Sunil was. I'm like, heck, what's the point? All the problems going to happen after the surgery, and she's going to be in house at that time anyway. So what's Kangaroo going to help? But now after hearing that even Sunil would put her on some Kangaroo, I probably might bring her in and treat her with that. And then resumption after the surgery, of course, will be, I think, single antiplatelet because she's still high bleeding risk. And then we'll leave that choice to her primary care.
Sheesh, as is your custom, this was thoughtfully and expertly executed. I thought that was really a great example and a great discussion of how to navigate when you inherit a really sick patient with multiple comorbid conditions, not the least of which is severe coronary disease. I thought that was really a very thoughtful approach. It was really excellent.
Thanks, guys. I appreciate it. Thank you for all the input.
I vote we do another case. How do you guys feel?
Oh,
yeah, let's do it.
Right. So into it now. So.
Okay, our next case, Bimal Padalia has a great case on OCT guided intervention. Bimal, take it away. What do you have?
It's always hard going after someone as brilliant as Ashish, but I'm going to do my best shot. I'm one of the lucky graduates of a fellowship that we use a lot of intracoronary imaging. So what I want to do is show how I, through a case-based presentation, use OCT to guide a high-risk PCI. So as a physician and a specialty that has numerous testing available, it's always good to know what the strengths and weaknesses are of what we have available. So these are 3 rules that I live by in the cath lab. One is angiography has severe limitations and as a standalone imaging modality. 2, routine use of IVUS or OCT or intracoronary imaging in general leads to better clinical outcomes. And then 3, when possible, meticulous planning, for example, having a plan A or B or C, simplifies your procedural decision-making when things come up in the lab. So these truths are an innate part of my OCT workflow. And what I'd like to do is show you how I think about OCT with a little bit of Motown influence. So, So why is angiography so limited? Well, coronary angiography, as you know, is a simple luminogram. It allows for accurate assessment, or it rarely allows for accurate assessment of physiology, for example, showing the true ischemic potential of a coronary lesion, or of anatomy, the true characteristics and the makeup of the lesion. And these two concepts are very important to understand prior to undertaking any coronary intervention. The interventional story of using intracoronary imaging to guide PCI and then the subsequent benefits has been a very elegant story. Dr. Colombo first showed in the early 1990s that using IVUS to achieve adequate post-dilation led to not needing anticoagulation after PCI. And in the modern era, study after study has shown that early intracoronary imaging with PCI leads to reduced MACE in many subsets of patients. Those include those with small vessels, long lesions, bifurcations, or left mains. And this is true for both baremetal stents and drug-eluting stents. Over the last decade, using light technology, or OCT, to provide intimate visualization of the coronary artery has added to the decades of data established with IVUS use. In the doctor's study, OCT-guided PCI was associated with a higher post-procedure FFR. And this was parallel with more stent optimization used in the OCT arm. Previous studies, including the FAME series of studies, have shown better clinical outcomes with higher FFR. And then we have learned a lot about what drives MACE by looking at registry data using OCT. In the CLI OPCI-2 study from Italy, MACE was predicted by three main factors, and that was minimal stent area of less than 4.5 millimeters squared, which is malexpansion, residual proximal and distal narrowing, and distal edge dissections. So interestingly, proximal edge dissections, malappositions without malexpansion, and tissue prolapse were not necessarily associated with higher MACE. So most of our recent data with OCT has been gleaned with the Illumian series of trials. Illumian 1 showed that by using intracoronary imaging, OCT in this case, procedural decision-making was impacted 66% of the time, 57% during the lesion prep process, and 27% in the post-PCI optimization process. And then Illumian 2 showed that OCT guidance, when compared to propensity-matched IVUS guidance, your MSA or minimal stent area was no different. And naturally, Illumian 3 was performed, which randomized the use of IVUS, OCT, and angiography in PCI. And again, the MSA or minimal stent area was substantially improved when imaging guidance was used compared to angiography alone. And OCT was better than IVUS at identifying certain anatomic factors that have traditionally led to higher MACE, malexpansion and malapposition. Currently, Illumian 4, which is powered to look at clinical outcomes in patients with complex lesions, they're randomizing patients to OCT use and angiographic guidance alone. So with that background, that leads us to how can we use OCT guidance to perform really good precision PCI. And so with the help of a very famous Jackson 5 song, I've characterized PCI into three main phases.
Nice touch. Nice touch.
Like the Motown, the Michigan reference there. There you go. So the pre-stent evaluation, the stent placement, and the post-stent evaluation. And I use song lyrics to aid in recalling what to evaluate for in each phase. So I know this song predates me, but it's a famous song, and it has catchy enough lyrics that most people can remember it. So then you remember the lyrics go, all you got to do is repeat after me. Oh, ABC, easy as 1, 2, 3, simple as do, re, mi. So in the pre-stent phase, after your pre-stent OCT run, you want to understand the basic A or anatomy of the lesion, and this aids in understanding the pathophysiology. Next, you want to plan on the dimensions of your stent implant by understanding the B or the breadth of the coronary segment being treated, which is your length and your diameter. And then lastly, you should focus on the C, or the calcification of the lesion. That will help you decide how aggressive you need to prepare the vessel, which is very important for the lesion and the stent to expand. In the stent placement phase, you use your co-registration with your OCT and your markers. The first marker is a proximal edge. The second marker is actually the lesion, and the third marker is your distal edge. And you can align your stent precisely to what you see on the angiogram. And then the last phase, the post-stent phase, you use your post-stent OCT run to rule out markers of MACE. So DO or D is ruling out dissections. RAY or R is you're recalculating the distal reference, which sometimes increases post-procedure. And then ME or M is ruling out malexpansion and malapposition. So let me kind of demonstrate how this can be applied to a case. So here we have an 84-year-old male. His cardiac risk factors included dyslipidemia, hypertension, and diabetes, and he presented with accelerating angina symptoms. His exam was notable for an irregular pulse and a lack of heart failure. He was on medications for guideline recommended therapy for dyslipidemia, hypertension, and AFib, and his symptoms persisted despite a control of his AFib. And his troponin, when he first came in, peaked at 5.5, consistent with a non-ST elevation myocardial infarction. I took him to the lab. This is an AP auto view of his left system. And one can see the what looks like a highly calcified, definitely stenosed lesion in the mid to distal left main. He had some distal RCA disease as well. He was hemodynamically stable and chest pain free at rest. So I took him off the table to discuss alternatives to his revascularization. And because of his lower syntax score and his preference, we pursued PCI. So the next day, after a heart team approach, I brought him back. Used again the right radial 7 French access and a 7 French CLS3 guide for engagement. Here's just another view coming up here of the lesion. And so angiographically, it appeared to me to be the lesion that was to the left main only. So the efficient thing with OCT is that with one picture, you get a 3D understanding of the entire vessel. And that's not just OCT, that's with IVUS. And so you get an infinite amount of more information than you would get in one angiographic view. So a pre-treatment OCT was performed.
Bimal, can I ask you 2 questions about the OCT run? Number one, the Dragonfly, I think, is a far better imaging catheter than the ultrasound or IVUS catheters, without a doubt. But the challenge has always been the perfect settings on the contrast injection timing and et cetera. So typically we'd been taught to use that 4/16 with a rate of rise of 0.3 for a left injection, and make sure that there's no blowback into the aorta, like in your case, it seems like there was. And I end up having to frequently repeat my OCT image because the first one, for whatever reason, never works. So my question is, help me to try. I mean, I know that Zia talks about using saline and other things like that, but I'm not even there past getting the right settings for contrast. So, I need help to get this right.
Yeah, well, in fellowship, I basically don't like using the assist for my OCT.
See, that's my first mistake.
I use a manifold. And what Dr. Costa and Dr. Becerra in fellowship kind of taught us was, number one, you always want to make sure you're well engaged, so you're not going to get too much blowback. But also that it's a nice ramp up injection. So it's how you kind of increase that velocity and fill the vessel. And pretty much all my OCT runs are done with 10 cc's or less of contrast with using a manifold. And what I've found is in areas where we predominantly use assist, because you don't control necessarily, and they tell me there's ways of doing it, but because you're not really controlling the actual ramp up, the volume of contrast then you have to use is a little bit higher.
I see.
But as we all know, too much contrast is poison, and I love using the manifold. It'll be interesting to know what Dr. Jaffer and Dr. Rao, when you use OCT, if you have a preference in using a manifold or assist, in ways you reduce contrast use.
Yeah, so I think you make some great points. I also work at the VA hospital here, and our operators at the VA are almost 100% imaging guided PCI, and the vast majority of that imaging is OCT. And we have co-registration. It is really an invaluable tool to plan and execute PCI. Having said that, we did switch over probably about 5-6 years ago to 100% assist. So we do use assist, and the easy settings, Ashish, for assist, if you want to use it, I agree with Bimal. I mean, you do end up using more contrast than you would with a manifold, but the easy settings is don't change anything on the assist except for the volume.
Malik, if this were 5 years ago, we were hearing, that everything left main had to be intravascular ultrasound, but now Bimal is talking about left main guided PCI with OCT. Your thoughts? I know you're willing to use OCT in the left main.
Absolutely. I think the most important thing is adjunctive imaging to assess, characterize the left main, as well as to help in guiding stent optimization and placement, as Bimal alluded to. But definitely, I think in this day and age, people are much more comfortable using OCT for left main stenoses and treatment, especially if you can get proper engagement. And probably if you don't always have osteal disease, I think it can be done very effectively. And people are much more likely to use OCT. And the imaging and characterization has been outstanding recently. And then more than anything else, I think, as Bimal alluded to, the data would suggest that outcomes are better off when utilizing OCT for intracoronary stenting.
Right. So as this image plays from distal to proximal left to right, you first notice that the OCT pullback is played simultaneously with a cine image from the upper left corner. And in essence, the OCT is then overlaid with the angiographic image. And the lumen profile mode in the middle of the screen, it gives you a 3D visualization of the entire segment. So it allows you to see in an opened up vessel normal segments and areas that are narrowed. When the OCT passes through the lesion, you notice that there's quite a bit of calcium there in the diseased left main, and there's a small area that may be a plaque rupture. So this is the A portion of phase 1.
Bimal, sorry to interrupt again. Can you show for the people that are on the webcast how calcium is identified? Because I know that early users of OCT have trouble figuring that out.
Right. So calcium
with your marker.
You can actually see it really well. Kind of this picture was taken into the LAD. So as I move over here, you're going to see a dropout of signal. So it's going to appear dark, but you're going to see that the borders are very easily demarcated. So you can grab a pointer and actually look at the demarcation. So this is a calcium nodule that is appearing in the vessel. And it's important to then also know, it's hard to sometimes figure out lipid from calcium in just one image. You need to really show the image as it's playing, because what you may have is a large area of calcification that is a big nodule. And that's kind of what's going on in the left main here. So a dropout of image, it's going to appear dark, but as opposed to lipid, which you're going to have diffuse borders, with calcium, you're going to have very sharp borders where you can use a pencil or a pen to outline the borders.
Thank you.
So the A portion, you see a highly calcific lesion and with a possible plaque rupture. So next is understanding then the breadth of the lesion, the area that's likely to be treated. So what I like to use is the lumen profile again, the mode in the middle there, to aid in measuring the stent length. The vertical bars can be placed at areas on the lumen profile that appear to be normal or larger. And at both the distal vertical bar and the proximal vertical bar, the cross-sectional image can be interrogated to verify if it is a good place to land the stent, meaning it's more of a normal vessel or it has fibrotic disease, areas that you're probably not going to dissect. And then again, similar to IVUS, you'd like to measure kind of media to media, EEL to EEL if possible, only if you're able to see the EEL. The distal diameter measurement will be the diameter then of the stent, similar to when you use IVUS. And then the length between the two vertical bars is going to be the length of the stent.
So would you, sorry to interrupt again. So would you, for example, in this case, the distal reference media to media measures out to be 4.5. Probably lumen to lumen would be 4. I was taught for OCT, you use your distal reference lumen as the size that you would use. So you would downsize from what you're seeing from media to media by 0.5 millimeter. Am I correct?
Yeah, 0.25 or 0.5 millimeter. So if you're able to see EEL, then that number you get, you downsize to the next available stent size.
Sure.
And then if you're not able to see EEL and you use lumen, then you upsize to the next available stent. Exactly.
Thank you. Yeah, thank you. That's great. Yeah. These are subtle differences between IVUS and OCT, and the audience should be able to, because as Sunil rightly said, you can go into IVUS and OCT all day long, but if you don't know how to interpret the images from them, it makes no sense.
Exactly.
Absolutely. First step is doing it. Second step is knowing what you're looking at. That's for sure. And so then lastly, C, which allows you to focus on the amount of calcium in the lesion. We know that calcium is the bane of stent expansion. If you underestimate it, it's going to make your procedure long. So if there is significant superficial nodular calcium, stent expansion without proper vessel prep is going to be a huge problem. The calcium score for this patient using an OCT algorithm is 4 out of 4. As it is greater than 180 degrees of arc of the vessel, it covers more than 5 millimeters of the length, and the depth is more than 0.5 millimeters. So here in the next, I kind of walk you through the calcium scoring system. This is an OCT-based point system for calcium, and it was devised by the Columbia Group in 2018. And in brief, they showed that for each metric of higher calcification, which is thickness, length, and vessel arc, under expansion occurred to a higher degree. So this gives credence to the need for better vessel prep on those with calcium scores of 3 or 4.
And this is in contrast to IVUS, am I correct? Because IVUS does not give you any information about thickness. So this is additive information that OCT provides that you don't get with intravascular ultrasound.
Absolutely.
Because you don't have penetration into the calcium.
It's hard that you can tell whether it's superficial or deep, but the thickness of the calcium is very hard to tell with IVUS use, just because you have a dropout of signal. The nice thing with OCT is you can see behind the calcium and you can kind of demarcate that. Exactly. So based on the first OCT run and our phase 1 understanding, our strategy will be lesion modification of calcium with rotational arthrectomy, predilation with a 4.0 or a 4.5 balloon, stent placement with a 4.0 by 18 drug-eluting stent, and then post-dilation with a 4.5 NC balloon in the distal portion of the stented area and by a 5.0 NC balloon in the proximal portion of the.
Bimal, how important is it when you're done with this very well thought out strategy to image again?
It's still going to be very important to then figure out which will be the phase 3 that I talk about, and ruling out things that may increase the risk of MACE.
That's the do re mi.
However, yeah. What I find is you already have the OCT out and ready to use on the tool. Doing the first run before you're committed to doing anything, I still find is the most important one because it can simplify things. You may go ahead and be a little bit more aggressive with your vessel prep before you actually put your stent in that doesn't expand well.
Okay, so
So-
take
so Neil- Yeah, one sec. So Neil and Farouk, CSI, lithoplasty, rotational atherectomy. Any preference of one versus the other, or any reason to pick one over the other?
So we've switched almost completely over to CSI just because of the ease of use, although RotaPro is quite easy to use nowadays. I think for aortoosteal lesions, rotational atherectomy offers some advantages. The Shockwave balloon is very, very attractive. I mean, I think once it becomes commercially available, that's going to really, I think, dry up a lot of our atherectomy business. It's quite effective, and it's bulky, though. I mean, it doesn't deliver all that easily. So, you know, there may be a role for combining some of these therapies, quite frankly.
And superficial versus deep, I mean, the thinking being lithoplasty may be more valuable in deeper calcium, whereas you might still need some sort of a cracking mechanism, either with atherectomy with roto or CSI, to create the fissures with in the superficial calcium, because you're not really going to get that with a balloon expansion strategy alone,
Right.
whether it's with lithoplasty or with an NC balloon.
Farouk, do you have a preference?
I think all great points. I think this case, by the way, is a really nice case and a great way to use imaging. And I really think this is a good OCT environment with being mid-shaft, good guide engagement, co-registration. You're really planning to just do 2 runs and minimize the amount of contrast. I think that's great. I would favor rotational atherectomy in this case because of the constrained size. And the reason I feel this way is 2 reasons. One is the nodular calcium. This really is a surface-based environment. I agree with the assessment memo, well characterized. So I think that we really need to focus on the surface. I'm not so worried about the deeper components just yet. And there is a suggestion of an ulcer just distal to the stenosis. And anytime I see that with a orbital-based orbit that is a little less predictable, I would tend to shy away from that just in case I were to catch an edge of that ulcer. And so that would be my preference, is 1.5 NC or scoring. If not possible, then I think we would talk about 1.75 or orbital if I really couldn't expand after that.
So take us through it, Bima. What do we do?
Yeah. So I used a 1.5 millimeter rotational atherectomy burr, and
Where's the pacemaker? Where's the impeller?
Right.
Exactly.
That'll
So
be our next case. Our next case is
just this is a little bit or a lot less complex than the case that you showed. But again, this guy was chest pain free, systolic blood pressure is over 130, EDP was normal, EF was normal, and so and again, radial access, he wasn't quite as big as your patient was, but added access obviously increases. I thought I could do this without any support. I did have the Impella. I didn't have it open, obviously, but I had the Impella rep available in case I needed it. So, this was thought out, but
I was teasing, you know that.
I know.
It's good. You got to ward off the evil spirits on a case like this. Right?
Yeah.
So whatever you need to do.
What is remarkable is the proximal LAD by angiography does not look anywhere near 4.0. And it was so important to really confirm that, because you're going to pick the right stent. And it's so important for this case.
Right. So this is the angiogram post atherectomy without any balloons. It's very minimal improvement in lesion, but again, the idea of atherectomy is to modify the nodular calcium or provide a type of micro dissections that will facilitate expansion. This is a short 4.0 millimeter compliant balloon that, at least at the lesion site, at nominal pressures, grows to its full profile. And then after balloon inflation, what I noted what seemed to indicate, at least in the caudal view, a possible dissection, because you kind of see that vessel, this compression of the vessel seen in this caudal view. And I took one more view from the cranial view, and you can see that there definitely is a dissection there in the left main, likely extending into the LAD. And so further injections at this point in time would be poorly advised as you propagate that dissection plane either further into the LAD or even worse into the CERP.
But not unexpected. Calcified lesion, 4-millimeter balloon. This is expected. This is nothing to be panicking about. Right?
And I think what Dr. Jafford mentioned was that ulcer kind of in that distal left main into the LAD. I think that was the area where there was kind of more ballooning in that area of the dissection there.
How do you tolerate it? Is it okay?
Very well. Didn't have chest pain, no hemodynamic problems.
Great.
So as a case so far, we've meticulously planned out and we think we know exactly what we're going to do, but you can now go back to the previous OCT run and extend your plan into stenting into that proximal LAD. So what I did was I remeasured the distal reference to resize the diameter of the stent, extended the vertical stent into the LAD now. Now my new stent strategy is going to be a 3.5 by 23 drug-eluting stent.
See, that's the difference between you and me. You're smarter than me. I would have done the 4018, dissected the edge, and then had to put another one behind that. So that's amazing. That's super nice. Well done. That's great.
So then phase 2, precision PCI then involves using your co-registration to stent the desired segment. One, which is the blue marker, corresponds to the proximal reference on the OCT. 2 corresponds to where the lesion is. The lesion is well covered. And then 3 corresponds to the distal reference on the OCT. And so you can use your co-registration to help stent exactly the artery without using more dye. And then we also know from the OCT run that the mid portion of the stented area was a 4.5 vessel. So this was dilated with a 4.5 NC. And let me go back here. Yeah. So we also know that the proximal part of the stented area was 5.0, and so that was post-dilated with a 5.0 NC balloon. And so that finally leads us to phase 3 of precision PCI, where we look at the post-PCI OCT run. So this run focuses then on ruling out any anatomical features that could increase the risk of MACE. So in the post-PCI run, in addition to the co-registration angiogram that you see in the left upper corner, you can see the longitudinal view picks up the borders of the stent automatically. And then in the lumen profile mode, you see a nice now tapering of the vessel. So phase 3 starts with DO or D, ruling out dissections. By moving the area of interest to the distal stent edge, one can see there's no obvious major dissections there. At the proximal stent edge, there is a minor dissection at around 10 o'clock where the blue arrow is on the slide. But again, together, there are no major edge dissections that need addressing. Next, we need to confirm that the adequate post-dilation was performed, especially at the distal vessel. We know in up to 20% of cases that distal vessel becomes larger with improved flow. And here we focus on Ray or R and the resize of that distal reference vessel. In this case, I didn't put it here, but the measurement was still the same. It was 3.5 millimeters. And then finally, and probably most importantly, we focus on me or M, which is ruling out major malapposition and malexpansion. The software aids in calculating expansion by having the stent. The distal half is compared to the distal stent edge, and the proximal half is compared to the proximal stent edge. And as you can see on both images, depending on what definition you use for good expansion, both areas are greater than 85% expanded. The red coded struts indicate areas where there may be more than 300 micrometers in malapposition. And you could see some red struts there in the proximal stent edge. But here, the stent is well expanded, probably malapposed because of some degree of calcium there. So further stent optimization is not needed in this area.
When would you consider a red area that would need treatment? Isn't there a length of the malapose segment?
It's more if it's associated with expansion. If it is associated with malexpansion, without a doubt, it needs treatment. What are thoughts on that, Dr. Jaffer?
There's never been a trial that has shown that acute stent malapposition by itself is predictive of poor outcomes.
Got it.
At 400 microns in the Prestige trial, they use that kind of as one criteria for considering it. I think as a perfectionist, one would not be wrong to consider additional post-dilatation, assuming that the distal edge right after that did not narrow aggressively. But I think you would absolutely leave this and feel comfortable that you get a fine result for outcomes. You can't point to an inferior result.
That was outstanding. That was amazing.
I got to tell you, man, looking at this last angiogram and correlating that with the OCT, you were surgical with this.
Yeah.
I think
this is the final angiographic picture, which
right.
you see good satisfactory image, well-placed stent, no flow limiting dissections, preserved TIMI flow and LAD and CIRC. So that's what you get with OCT guided precision PCI. All you got to do is repeat after me. ABC is easy as 1, 2, 3, simple as do, re, mi.
We need you to sing that now.
Yeah.
That's the next step.
See, so, Dr.
I'm
White,
the only one. I'm the only one.
Question.
Genetics.
So what kind of a remark was that? That's surgical precision? What the heck is that about?
No, I said
like I dig at the Excel investigators, or what is that?
I said he was surgical with that.
So what does that even mean? I would say he was performing contemporary PCI of 2020 that we expect of all our young operators moving forward. That's the only way we're going to match results like this. I'm putting this to test against any surgical outcome, whether it's a Lima, whether it's a surgical arterial conduit. I mean, it just doesn't make any sense that we've been so far short selling ourselves, comparing poorly performed PCI with a surgical gold standard.
Let me ask you a question then. Let me ask you a question. I think you're 100% right, and I agree with you in that when you look at what he did with this case and what you did with your case, and I'd like the editor's view on this too, incidentally, is the XL trial a little bit on the antiquated side? In other words, imaging wasn't mandated. There was a high degree of imaging, but not universally. Is XL trial is the XL trial an antiquated trial by today's standards based on what you've seen here today?
Yeah, so I think it's a good question. It's obviously a very provocative one. I think what we have to keep in mind is that, I mean, what this case is, PCI being practiced at its highest level. I mean, Bimal, when he did this OCT and he saw the calcium, he didn't shy away from doing atherectomy. We've seen plenty of cases where people do imaging, they see calcium, they say, let me just try the balloon. Oh, the balloon seems to go okay. And they struggle to put the stent in. They accept this sort of suboptimal stent result. But we've got a lot of work to do to get people to practice like this. So in that sense, I would argue that many PCI trials are potentially outdated. We all need to be practicing at this level.
These are great points. I think that it's clearly shown also with left main that volume matters. And people who don't have the opportunity to continually hone their craft over, frequently over, every few weeks in these situations, won't spend the time because there's more of a sense of urgency and just wanting to fix and be done because of the stress of the left main. So this is clearly something where a seasoned operator doing a good job can have outstanding outcomes. I will make one editorial comment from the Excel trial. Like, one of the ways that I counsel patients, certainly from all criteria, this is probably a low risk syntax score overall. And it's, again, a beautiful technical result. Good DAP candidate, I'm sure, and non-low STS score. So probably above average surgical risk at his age and with other CKD and so forth. But one of the ways that I counsel is I will look at the time horizon. Because just like we saw, if we lose the ischemia parallel of curves crossing at 3 or 4 years, favoring PCI, I also think that we have to be fair and look at the Excel trial, crossing at 3 or 4 years from that trial. So if someone has a 10 to 20 year, 30-year time horizon, and they're a low risk for Lima, I'm absolutely happy to mention that as a fair option for patients. If they're short term, like this patient, who had 84, and you're looking at their syntax score, STS2, syntax 2 score, mortality is going to be over 50% at 4 years. PCI is perfect, absolutely perfect in this situation.
So let me make one point, go back to Bimal, what you said at the beginning, and Mullik, you can jump in here. When we, as a program, looked at where we were in 2014 and 2015, I looked at as our program at Honor Health as a whole, and I saw a very clear deficiency in imaging. And when we went to hire a new young interventionalist, we weren't subtle about the fact that we went to a program. We looked at candidates from programs who had high imaging adoption and high expertise in imaging. And that's how that's why we asked Bimal to come and join our group, because this kind of imaging was extremely important to us. Mullik, you want to comment on that?
No, absolutely. I think one of the things that you can see implicit in everything that Dr. Padalia and Bimal has said here today is just that it's very patient-centered. If we really want to take care of our patients in the best manner possible, it's almost incumbent upon us to make sure that we offer this sort of therapy to them, to make sure that we have adjunctive imaging done at the same time. And if we're ever going to keep up with surgery or make sure that we're as good as, or better than surgery, I think that we're going to need to utilize things like OCT and IVUS to its fullest capacity.
Sheesh, how do we, you're a program director, how do we get programs to make as a central part of their training this type of imaging? How do we do it?
I think it starts with leading by example. I mean, I think, when you look at programs and you poll even academic medical centers, the rate of adoption of any kind of imaging is abysmal. I mean, it really is. And I think that's a shame on us. And I think we need to challenge ourselves to do better. And this whole, every excuse that people have made related to, initially it was reimbursement, then it was time, then it was workflow. And it just keeps getting more and more pathetic in terms of how lame these excuses are. And I think ultimately, once you have an integrated system in your lab, which I hope most AMCs have, at least 1 or 2 labs in their system that are integrated, and Farouk and Sunil can comment on that, it really becomes your DNA. So in my lab, there's an IVUS catheter pulled before I even start an intervention on every case. So it is not an option. It is a mandatory requirement. I will not do an intervention, even if it's a type A lesion, without imaging. So that's the kind of example, if you set to your fellows, I'm hoping that they leave with seeing the advantages of that, because we're an open lab. There are operators that do procedures with traditional angiographic based results, and Obviously, the outcomes are not apparently different in the end of the case or even at the index hospitalization. But how do you ingrain into the minds of a young operator that you're looking at the life of the patient? You're looking at TLR rates. You're looking at MACE rates in the future when 2-3 years later, they're no longer an interventional fellow, but somebody comes back in with a STEMI from an underdeployed stent. They recognize that having done it right the first time is your best opportunity. Once somebody has metal in that's been deployed poorly, all options down the road are frankly inferior, whether it's redilating, whether it's lasering, whether it's rotoing, whether it's brachytherapy. Anything you do after 1 or 2 layers of stent have been placed is a disaster. And I think that's just the fact. And if you can ingrain that into every fellow, doing it right the first time involves using imaging, then we're leaving a legacy that's worth something.
So closing comments, Farouk, that was great, Ashish. Farouk, what's your final comment on these cases we saw today?
As Sunil had mentioned, these are being done at a truly expert level with so much care for the patient at the center of this case, but then using really state-of-the-art techniques from devices to modify calcified lesions, as well as to really understand through imaging, what our target expansions and vessel sizes and stents should be. It takes the guesswork out. There's none of this, I'm going to just wing it and then, okay, I put in a second stent because there was an edge dissection because I oversized or I landed in a huge plaque burden zone. The guesswork is taken out, and that's what you need, is particularly in left main intervention. There is just much less margin for error if there is a stent failure. And so these are really commendable cases. I think the guys did a great job.
Sunil, as is appropriate, you get the final word.
Yeah. Well, first of all, I want to thank you for inviting me to this. It's fantastic. Lots to learn with this webcast, decision-making, imaging, and how you really approach these complex cases. I think my final thought is you never want to leave the lab with any kind of question mark in your mind about how well you did. And I think imaging allows you to erase that question mark.
Yeah, we did a session earlier today, and Jim Hermiller said, you never want to leave the lab thinking you did the right thing. You want to know you did the right thing and the patient is going to do well. And I think that's typical of these two examples. I want to thank our expert panel. This was really a spectacular session and a very, very deep dive on image-guided coronary intervention and really complex lesions. We are proud to bring you SIF Virtual. There will be many more sessions coming over the next 60 to 90 days. I want to thank our expert panel and thank you for joining us at SIF Virtual.